Good morning, everyone, and happy Thursday. Just one more day to Friday. Welcome to our webinar today, Disease Management is Dead, Your Clinicians Are Overwhelmed, and You're Headed Towards Value-Based Reimbursement. We're very happy to have you join us today. My name is Beth, and I'll be moderating. So just a few quick housekeeping details. Our speakers welcome your questions today, so take a look at the control panel in the upper right-hand corner of the screen, and you'll see an area at the bottom where it says Type Questions Here. Use that feature to type in any questions, and our presenters will be glad to answer them at the end of our webinar. We will also be having two polls today, and we encourage you to participate. When the polling slides appear, just click on the answer that best represents your answer to the question, and we'll share the aggregate results with you live. Now, a bit of background on Healthy Interactions, who brings you this webinar today. For over a decade, Healthy Interactions has provided validated patient engagement programs that improve outcomes for people with chronic diseases. I would guess that many of you are familiar with Healthy Interactions through our Conversation Map programs, and now we also offer digital coaching platforms for scaled population management. Over 100,000 healthcare professionals in 120 countries have been trained to facilitate our programs. Over 30 clinical and customer studies have validated their efficacy, and we are very proud to say that over 25 million people have benefited from our programs. Now, I'm pleased to introduce our speakers, Dr. David Moen and Barbara Eichorst. Dr. Moen, a physician consultant, is our strategic and clinical advisor. He has spent his career providing thought leadership to teams for high-risk patients in hospitals, clinics, and community settings. Prior to establishing his consulting practice, Dr. Moen worked with the Fairview Health System in Minneapolis for 25 years, first as an emergency physician and then physician executive. During his last 5 years at Fairview, he served as medical director of innovation and president and CEO of the Fairview Health Network, where he led Fairview to be named a Pioneer ACO by Medicare. Our own Barbara Eichorst, Clinical Vice President, who is an internationally known asset in the chronic disease management arena, brings extensive clinical care and program administration experience to Healthy Interactions with a driving passion and a generous dose of joy, which you will likely experience today. She is currently leading the development and implementation of global training, having contributed much to the advancement in diabetes care. In addition to publishing numerous articles, she holds a master's degree of science in nutrition education, and most recently has been working toward her doctorate in the field of clinical care. And with that, I invite Dr. Moen and Barbara to take it from here.
Thank you, Beth and Barbara. It's just an honor to be here to have this conversation with you today. And with all our listeners, thank you for joining us. And Barbara, you've had global experience in this field, and I think that has become so important as many of us are serving more diverse populations and we have health disparities to deal with. It's just a great time for us to begin a conversation about how we improve disease management services. So if I could have the next slide. We'd like to start with the patient's perspective. This really came to light for me about 2 years after I completed my residency. I was working in an emergency department. It was 3 a.m. It was very busy. And an unfortunate woman was wheeled by paramedics. She'd been badly beaten by her husband, and I saw her go by, and I got her name and looked in her health record, and sure enough, it was her 3rd visit in 6 months, and she'd been badly beaten on 2 prior occasions and had been counseled about getting out of her situation, and here she was again. And to be honest, I was frustrated, I was busy, and I just walked into her room and I said, "Listen, lady, you got to leave this guy. What are you thinking? He's going to kill you." And she looked up at me, and with the one eye that wasn't swollen shut, she focused on my face, and she sat up slowly, and she grabbed my scrubs right in the front on my chest, and she pushed me into the wall. And she said, "I've left him 3 times. I've moved me and my kids 3 times. I have stayed in shelters, gotten counseling. I have restraining orders in 2 different counties. What else would you like me to do? She took her hand off and she grabbed her things and walked out of the emergency department, and I stood there feeling completely humiliated. I wasn't prepared for this at all, and I left my shift that morning, went home, I couldn't sleep, I tossed and turned. And finally, a few days later, I talked to a nurse who witnessed this, who was a friend of mine, and I said, you know, that didn't go very well. And she said, no, it really didn't. And I said, what should we do about this? She said, well, why don't we go out and visit some shelters? And we spent the next 6 months out in domestic violence shelters asking women about their experiences, and it completely changed my perspective. So here's what I didn't understand that night was I was addressing her from a white male physician perspective, and that didn't work. Here's what I learned is our interactions need to start from the patient's perspective. And we often say that, but actually doing that is something that requires us to really think about the biases we bring to the occasion and what it is that we need to learn and do together to improve the way we engage patients. So today we're going to talk about a number of things. First of all, and if I could have the next slide, that would be great. What do we mean by disease management? First of all, what we mean is that disease management is a huge industry. It's a multi-billion-dollar industry in the U.S. Employers buy disease management from payers or from other vendors. And what has occurred is that this system just doesn't work very well. Patients that need it the most aren't using it, and it costs a lot of money. So we're going to talk about why that doesn't work and gain your perspective as well. Next, we're going to move on to the economics, and we'll do this briefly. Most of you know this well, and then we're going to talk about patient engagement, effective behavior change scaled to true population change. And this is where Barbara's experience and the experience of healthy interactions is so key. And then we'll close with how do you grow a program to an education program that's actually effective and scalable. So before we start that discussion, we'd like to ask you a question. What is your greatest challenge? And we'd like you to use your voting function on the webinar here. What's your greatest challenge in ensuring that your chronic disease improvement model is effective? You've got 4 choices there, and if you could just take a moment to vote, that would be great. And let me know when we've got some results, and we'll put those up, and then Barbara and I'll look at what you think and tailor our presentation based on your input at this stage. All right, so it looks like engagement is the leader and reimbursement and not integrated with medical care and personal touch at scale. So all of them appear to be issues to some of you with engagement and reimbursement leading the pack. Engagement especially, and I think that's been my experience out in the marketplace. People are really struggling with how do we engage high-risk patients. Barbara, what's your perspective?
And I kind of share the same perspective. Especially with diabetes care, we kind of have an indication that low engagement and low reimbursement are both barriers to appropriate clinical care outcomes. But like we know that only 40 to 50% of people with diabetes end up seeing a diabetes educator as a result of a physician's recommendation. So even though the physician might be referring the patients to us, but only 40 to 50 of them will end up seeing us. And those who would see us do not get the best outcomes despite of being educated. Like we know that only about 50% of people achieve their goals for A1C, blood pressure, and cholesterol, But what's interesting, only 20% achieve all those three, and we know that for disease prevention and also to minimizing the risk factors, we want to make sure that patients get blood pressure under control, cholesterol, and their blood glucose. And only 20% of the population who receive effective diabetes interventions are able to reach those goals. So clearly, those are the significant barriers. And then the final thing is that only 7% of Medicare beneficiaries who are eligible to receive the DSME are getting it. So you can see that the reimbursement and the low engagement is evident with those numbers.
Yeah, I was just on the phone with a large health system in the Midwest last week, and their physician leader said they have 21,000 people with diabetes and less than 1,000 of them have attended programs. And they have 10 diabetes educators, and they're losing money on their program as it is today, and they're faced with potentially cutting the program. So it's really a critical time for us to dig in. So let's move on to really look at these 4 areas of disease management, and let's, I think, reframe it. I think it's really, how do we care for patients with a chronic disease? So let's go on to the 4 areas that we highlighted in the poll. First of all, engagement. As you all identified as a huge issue, employers tell me that less than 5% of their patients sign up for these programs, and their frustration is the ones that need it the most are not accessing it. So they're not getting the return on investment as promised. Good example is people with a fitness benefit, 20 bucks off your health insurance. If you go to the fitness club, the people already going to the fitness club are now getting 20 bucks off, and not many people who aren't going have decided to go, so it's waste. Secondly, the integration. This is a huge issue. I hear doctors extremely frustrated about the nurses from New Jersey who call their patients and say, gee, you need to be on this medicine. They schedule an appointment. It's a medicine they were on 6 months ago and were taken off because they had a bad reaction. All waste. Personal touch doesn't scale. This really, what I hear is these things take time, and when I'm feeling under pressure to see patients, to bill accurately, to enter information in the EHR, this is challenging, and I certainly understand that. We understand that. Yet there are some nice solutions that have emerged to help us deal with that, and of course finally low reimbursement, which you all identified as the second issue, remains an issue, and I think that should pop up here on the slide as the 4th one. Low reimbursement is a major issue. So we'll really dig in on these 4. So let's get started. Next slide shows us about the health determinants. Those of you in the public health world really get this. We're just coming to grips with it on what I would call the acute care side of the delivery equation. What's interesting in the U.S., we spend so much on this 10%, the healthcare part of this, and we underspend in the other parts, so we end up with health outcomes that just don't translate on a population level like other countries do. So Barbara, given your global experience, I'd love to hear your perspective about this slide.
The blue circles with 50 and 40%, when it all boils down to behavior change. It's not as simple as just one behavior change. It takes a lot of different habits that need to be changed or modify daily tasks and also behaviors that people are used to. So in addressing the whole person, we then have to think about other circumstances that are barriers to behavior change, like psychological, or like with your story with your patient who had other issues to do than take care of themselves. Many of the people who have chronic conditions, it's not just about them, it's their family, it's their environment that creates a barrier to behavior change. But even the behavior change itself, it's a lot of things to do. People end up, they have to eat better, being active, monitor their outcomes, take medications, problem solve on a regular basis. What do I do if I have a higher blood glucose? I check, but like, what do I do with this? They might be able to monitor their blood pressure. They might be able to monitor their blood glucose, but do not have a skill set or understanding what to do as a result of those numbers. They also have to do a lot of problem solving and while they're reducing risk. But the most important thing is coping with those tasks and responsibilities that they need to be done. It's just a lot of work. So from the global perspective, it's a very local perspective. People everywhere, and the patient with diabetes or any other chronic condition, they eat, they live the same life anywhere we are. It's just we just as a healthcare professionals need to be aware of those barriers and help our patients overcome those.
Hard to do in a 15-minute provider visit. So let's talk about provider challenges. These are the things that we hear. Time constraints has been mentioned. Skill constraints. I really wasn't trained to think about what does it take to change someone's behavior. I was focused on what is the diagnosis and treatment? What's the knowledge that I need to impart? And that model, as you heard in the example of the woman who was battered, doesn't work very well. You also have a lot of frustration out there today as the incentives are changing, the tools aren't there, so we're still running an old fee-for-service, crank them through model at the provider level and with our nursing staff, but we're not really addressing the challenges. So let's move on to talk a little bit about the economics. And you know this well, so I'm just going to briefly touch on the next slide. Shows us where we spend our money, and I think you know this well. And you can see that diabetes has the potential to swamp our entire health system with its cost, but it's all our conditions really. Look at COPD, obesity, CHF, mental health conditions all require a model. And what we're going to talk about is a model that certainly applies to diabetes, but it translates to any chronic disease. And in the next slide, you'll see that, you know, this is the shift. And when you really look at this, where our focus becomes populations, you see that we really need to move from one-on-one into team-based continuums of care. And we need to think more about who's at risk and how do we engage them. So that's where we're going to put our focus from now on. So let's move on to patient engagement and behavior change. And this is where we really get into the meat of what we're going to talk about today. So if we could move on to the 4 things that we told you about. And what I know is that as providers, we have the opportunity to engage patients differently than a DM provider, a disease management provider, or than a health plan. So health plans in general struggle with their members calling them back. I was with a health plan recently, and they had an average of 1 out of 18 patients that returned phone calls. In the provider side at the Fairview system, when we measured this, we took some of the health plan capabilities, moved them for the provider side, and over 90% of people called back. So engagement, we can definitely get an uptick. Obviously, if disease management's integrated at the point of care, we solve that problem. And we're left with these 2 challenges. Personal touch doesn't scale, which we've got some great solutions out there right now that have been tested. And work really well, and then the reimbursement challenge. Barbara, anything else you want to add here?
No, it's just to summarize it's just that we're going towards the patient-centered intervention, and we focus on what the patient's needs are, and all of our efforts are really about partnering effectively with our patients.
So let's talk about the patient-centered model. It's shown well here. Barbara, I'd like you to talk about this through the lens of a dietitian and world-class educator, and I'd like you to also share maybe a patient perspective.
It took me at the beginning with patient-centered model. It's like we learn about the actual what to say, how to say it through interactions with our patients. So the more patient care we do, the more we listen to our patients, the more empathetic and more understanding we become. So it literally takes time to understand the patient's perspective and just listen to our patients more effectively. But this whole process, it has changed a little bit from acute care, where we only see a patient one time and we don't have any feedback from the patient. We don't know how did we do as clinicians, versus to a chronic conditions where we see patients more often and we kind of can learn from the patient, number one, because they tell us, or number two, they're not coming back. So if they're not coming back, oftentimes we wonder how come, you know, we have 10 hours of diabetes education within the first year and people are eligible and this is for free for them. How come they're not coming back? So kind of reflecting back on, is it what I have done wrong, or is it logistical, or is it any other reason? But this acute care model, where we break the leg and then we go to the doctor and we want the doctor to fix my leg and then to put it together, give me the medication, and I will do everything to minimize the pain and suffering that I'm going through. It's kind of like almost an easy model to implement. We want to be compliant and adhere as a patient, versus with chronic care model where most of, chronic conditions really do not hurt that much. It's kind of a silent condition where it kind of, before, you know, when we have a high blood glucose, it really doesn't hurt. But it's not good for the body because it's doing some damage there. So working with the patients with the chronic conditions is a little bit different. It kind of requires our participation, being a partner with them, achieve like this true concordance between provider and the patient, try to empower them, try to make them independent, because most of the work is done on their own. We only see them maybe a few hours in a year, but the actual intervention for the disease management is done by that individual. So I think that probably the best lesson for me as a clinician that I have learned about empathy and understanding from a perspective of a patient is becoming a patient myself. A few months ago, I saw an orthopedic surgeon for my knee because I have arthritis in my knee and it hurts a lot, and I needed to see a doctor. So my first interaction with him was just not a good interaction. So the first thing that he tells me is that my knee is of a lady who is 80 years old, and I'm 40, and I'm thinking 80-year-old, I'm imagining my mother. I'm like, I'm totally not like my mother. So this was like already pushed me back, but I did smile and responded nicely. So as far as the doctor was concerned, he did not know that he hurt my feelings with this 80-year-old lady thing. But that was not the worst out of it. The second thing, then I'm trying to be a good patient because I'm trying to please my doctor, because I want to I want to really do good for my knee and you know, everything. So I offered to lose 10 pounds, and I'm like, would it help if I lose 10 pounds? Not really believing that I need to, but I kind of am a dietitian, so I figured this is going to help to take the load out of my knee, and it would probably help. And his response was, he looks at my eyes and takes 2 fingers and puts it in my face, and he says, how about 20 pounds? So not only that I didn't believe, but I didn't lose the weight. And I was only sharing it as trying to be a good patient. Then he tells me something I don't want to hear. The sad thing is that he will never see me again, so he will not know that he hurt my feelings, but he turned me off as a patient, and I'm not engaged. I'm going to just see a different doctor. So I think that for me, in summary, this was probably the best lesson in empathy that I could have ever learned from my patients, like being a patient myself.
That is the way we learn, and sounds like a lost opportunity. The clinicians, physicians, nurses have such an opportunity as the most trusted profession. And if we could pull the next slide, we really highlight that. You know, I've been in that situation where things haven't gone well, and often patients, they're trying to please the clinicians, so they don't say anything, but then they don't do anything, or they go to somebody else and we never get the feedback we need. So it's really an opportunity for us to think about, how do our clinicians interact with patients? How are they supported in the chronic care model? It isn't by ramming all the work that needs to be done into the 15-minute doctor visit. It's about the clinicians understanding their role, understanding that their job is to engage the patient and invite the patient into the change. I had the opportunity to see another woman who had been battered that I had seen in the emergency department after I went through my personal transformation, and she didn't tell me when she was in the department that she was even battered. She had an injury of her eye, and she told me she fell and hit the tub, and she left that night. 18 months later, we had the opportunity to meet, and what she told me was that what she didn't want to tell me, she was very frightened. However, she said the thing that really made the difference for me is that you were empathetic, and you asked for permission to touch me before you examined me, and I had never experienced that in the hands of a male. And I had no idea that an action like that was so potent in her mind. I had learned, however, because women were so frightened in this situation, that me touching them was a frightening experience, and it was respectful to ask for permission. So these little things can make a huge difference. So let's move on to the believe, know, and act model. I love this model. It comes from many people, but the people who've influenced my thinking the most about this are Tim Brown, Daniel Pink, and Isaac Azen, who have done a lot of work in this area. And if you think about that woman with a domestic violence situation, certainly her beliefs were and her experiences were influencing how she was hearing me. And in the first example, when I said, why don't you leave, obviously that didn't resonate. However, in the second example, when she experienced trust, respect, and empathy, she didn't decide to make the change that night. It was 2 weeks later when she decided to talk to a trusted friend, and months later when she got counseling, and even months later when she decided to end the relationship. So this belief part is so critical, and we play the role of a trusted advisor, not by telling people what to do necessarily, but actually by being there for them and hearing where they are, and really creating a sense of safety and trust. So then we move on to know and act, and this is a lot of Daniel Pink's work, of course, and also Azen's work around social influence. And this is where I think your experience, Barbara, with groups is so critical and I'd love you just to expand a bit on your sense of the knowledge and act part of this equation.
Thank you. And I think that what you indicated, Dave, the group, experience with group, because this is a big aha moment, because we know that with one-on-one intervention or education, we can really individualize our care, because we talk to the patient eye to eye, and it's all about the patient. But now we are shifting into the group education, especially for like diabetes education. Group education is the only way to provide intervention. To be reimbursable, 9 hours have to be done with group education versus one is only one-on-one, because we know that group education produces as good as a results as one-on-one, and in some cases even better because you have a peer support. But I think that any way you do it with group or one-on-one, it's all about asking the right questions at the right time, make it patient-centered, and do not assume, and not waste our time telling patients information that they already know, or they're not willing to implement. So it's kind of like, as a clinician, I think the thing is just to relax and just have a really productive discussion with our patients. So what I do a lot with getting them from the know to act, because that's the most important thing, because patients already come in and they know a lot. So it doesn't take that much skills to teach. I mean, people can Google stuff and they can teach themselves. So when they come to see us, they're coming in for help for different reasons, not to know, but to help them to implement this information, put it into action. So I think that what good strategy is, like it works for me, is I use a confidence scale. So I ask the patients, like for example, on a scale of 1 to 10, how willing are you to lose 1 to 2 pounds per week? And they will say, I'm pretty willing. But then I'll follow up with the second question, how ready are you to do this? Like today, start today, and the confidence goes down to 2. So then, because then I know that maybe I can ask somebody, that person, like, what can you do? Well, maybe I can walk more. So kind of explore options and actions that are doable within leaving the office, instead of like, oh yeah, lose weight. Of course, everybody wants to lose weight, but will it get to a behavior change? So I think that it's in summary, kind of realize that it's about asking the patient what the patient can do, and us supporting the patient in that decision making, instead of us telling the things that people already know.
So that takes time. And let's talk about what it takes to get these things to go to scale. So here we've listed on the following slide what scalable solutions need to do, and we've got some examples from around the world. One of my favorite quotes is, the future's already here, it's just not evenly distributed. Much of this work has been done, and really our work is driving adoption of what we already know, not necessarily inventing something new. So tools that are accessible, I think a great example is a conversation map, which has been around for over 10 years. And the conversation maps are ways of taking the knowledge that we as providers think and know resides in our heads, comes from our training, and their conversations as diabetes educators or physicians or nurses that we're having hundreds of times a week. Well, those conversations actually are repeatable. The elements of that knowledge can be placed in a tool, and we'll show you a conversation map as an example of that. When you place knowledge like that in a tool, then the clinician knows that that knowledge has a way of being distributed that isn't just out of their head and mouth. So we move from me, the expert, having the knowledge, to me, the trusted advisor, engaging a person in a process that will bring them along on this believe, know, and act continuum. The next key to bringing things to scale is moving from one-on-one to group, and we've got great examples of group visits. There's a lot of group visits happening out there. What I think is really important is having good tools to support what happens in those group visits. Just getting people together in a group doesn't drive results as well as actually using known and evidence-based tools to drive results. And then I think there's some neat things happening in the digital world. I think the digital world is a shiny object, in my opinion. It's a great complement to personal interaction. I'm not as impressed with its performance as a standalone, especially for patients with chronic disease that require different levels of engagement. So let's look at a conversation map. The map we're looking at here comes from Healthy Interactions, and it's their map used in the United States. It looks different in the UK. It looks different in other countries where this tool is used. But in the US, this map guides someone on the journey of managing their diabetes. In the first session, 8 to 12 patients get together. There's a lot of metaphor in this map, and this map is a tool for people to have a conversation. And Barbara, you've taught thousands of people how to use these around the globe. Can you just expand upon your experience with the conversation map?
I sure will. And so my next slide would kind of showcase the map in action, because it is so much more than a tool. So we can see that there's several people sitting around the table. So the map itself is a large visual, and it has those metaphors. If you think about a picture is worth 1,000 words, but the metaphor is worth 1,000 pictures. So it kind of, as a visual, is really inviting for the discussion because it normalizes a lot of different things. A lot of times when we ask the patients, like, what would you like to talk about? They don't realize that that's even something that it's under their discussion, but when they look at the map, it kind of invite the discussion about things that they would even forget that this is a barrier. So it kind of creates a lot of aha moments and drives the discussion. The second thing is, for the map, it has the actual clinical information in it. So it is a full curriculum. Like, for example, in US, it's a full curriculum for DSME, for diabetes self-management education, and it's the only one that is developed in collaboration with American Diabetes Association, and it meets the standard 6 for DSME as a full curriculum. So the information in there is relevant for people with type 2 diabetes, and it covers everything that they the whole disease care. And then the third element of this whole experience is conversation questions. So we just ask the questions and the patients are discussing what needs to be discussed. And the group interaction is significant because 80% of talking is being done by participants. So that allows us as a facilitator or clinician to better assess patients' needs because they're telling us what's really going on in their life. So it's kind of easier for me or anybody who's doing a SOAP note from the patient when we have to do subjective, objective assessment in the plan. When we sit in there, just relax and we listen to what the patients are saying, and it really provides more targeted and more accurate interventions from our angle because the patients are coming up with their own solutions to their own problems. So I, as a clinician, do not have to figure out how to solve a patient's problem. The patient is solving it himself, which makes a huge difference. And then every MAP session would end with the goal setting. And the goals are kind of smarter than SMART goals because we all know about SMART goals, and my patients know, like, SMART goals are so good at it. They would say everything that I want to hear. The key is that they know SMART goals, but they don't know how to implement those SMART goals once they leave the session. So with the way that we do the SMART goals in the MAP session is a little bit different, where we kind of allow the patient to verbalize what they're going to do differently, what's meaningful to them, to help them to take that goal and put it into action and come up with the appropriate support network, and effective communication, how to ask for help, how to talk to their physician, and ask how to partner and achieve that goal. So it kind of closes the loop, how to talk to a wife who maybe is nagging the patient, and then it's telling them, you cannot have that, but I'm going to have that. So it's not just a goal setting, it's allowing a patient to effectively communicate and ask for the support that they need to implement that goal.
So the third aspect of getting this personal touch to scale is really the digital piece, which I think, when added to personal interactions, is powerful. So this slide is wonderful. You can see this is St. Peter's Square in 2005 when Pope Benedict was elected, and then you can see in 2013, same location, but the experience is different. And I think the first impression is, oh, the world's gone digital, everybody's watching this on their iPad. That's true. There is more accessibility to that experience digital, but notice that the people who are there are also in person and digital. The average person looks at their cell phone 109 times per day. So, you know, this combination is really the key in my opinion. And when you combine groups, when you combine tools that codify or build reliability into the conversation that are evidence-based, and you combine digital, I think that's the secret sauce. So let's move on. I think when I've been out around the world looking at disease management and what works and what doesn't work, healthy interactions jumps out because it combines all the elements that we've been talking about today. It combines the in-person experiences, the groups, the tools that make things happen, and the digital platform. Barbara, spend a few moments describing the operational aspects of these groups. How do people get engaged to attend? What are the groups like? How do they sign up for the apps? Those are the kind of questions I have.
So it's all the operational is how to integrate the in-person and digital together. So in-person and digital component, now we know that it's part of our intervention because patients are using the digital component, and we want to, as clinicians, we want to be part of that because a lot of if a lot of times they would use the technology or other things, but we clinicians are not part of it. So it's kind of like we're almost thrown off by it because our confidence level is low in understanding and in terms of how to interpret those results and help the patients do what they need to do as a result of it. So with the platform that I have been using with the conversational map tools, so it's a digital platform, so we would have, and this is an example of diabetes, for example, we would have a group of 3 to 10 individuals, and they are activated either in person with the map, so they'll come in and then set up the goals and everything. And then upon of the completion of the map session, we ask, so what are you going to do differently? And then how are you going to monitor your progress? And it's going to be the app, the conversation map app, to help them with the goal setting. So what's unique about that is that it takes I already have a relationship with that patient, so then I become a coach because most of the work upon of the completion of an in-person session is being done when I'm not with the patient. So as a coach, I'm able to communicate how is it going, and then a lot of times within a few days upon of the completion of an in-person intervention, their goal has changed. For example, they might get ill. Like one of my patients, he developed some other condition like gout in between, where he had to focus more on the pain management. So his goal became different, and I became more of a I coordinated his care and adjusted his activities to pain management, which was better priority because he had a high blood glucose and all that kind of stuff. And without that connection, he probably would have to Google stuff, and he would let go of the goal, and he accomplished the pain management, and then we kind of transitioned to the next stage. But that was a really good, and that is a good way for us to kind of keep in touch with the patients with a simple way because they already know us. And then also it's nice because the patients have the access to content that it's really consistent with what we are teaching them at the in-person intervention. And so they don't have to use other resources to find the information that they need in order to kind of, let's say, how many carbohydrates can I have, or all that kind of stuff. They can ask or they can look it up because it's part of the digital component. And tracking, of course, is the element there, like monitoring their progress and then evaluating their goal. And then, it takes few weeks to put a goal into the behavior. So it's kind of, it feels good to celebrate. I did this right. Okay, I am eating breakfast now. Now when I'm master in breakfast eating, I can then proceed to lunch, or I can do something different. So it's kind of, people feel good about accomplishing those goals by tracking it. So it makes a big difference. The other final component of this digital thing that I would like to share with you is that also it is nice because a lot of times patients do not see us for diabetes education until a few weeks because there's a waiting list, or the in-person sessions take a few weeks to get in. So we can activate the patient with the digital, start them on the app, so they already kind of are learning new things because it's in there, and I'm becoming their coach before they see me, which I'm allowing me to establish a relationship, and that patient is more likely to then come and see me because, as we know, but like I was saying in the beginning, but only 40 to 50% of patients get up to see a diabetes educator, even though they're referred by the doctor. So this is the way to kind of activate the patient at the doctor's office by signing them on for this goal setting and education with the app.
Sounds great. So when we look at the following slide, we see operationally these tools integrate. So they're capable of integrating with the EHR, And this becomes really important when we start talking about reimbursement, because we need documentation for the fact that these things are occurring. I'm sure many of you are aware of the chronic care code for Medicare, for instance. That's about $40 per person per month. That's a significant amount of revenue that can be achieved if people sign in as a beneficiary to that kind of program. Then we can bill for chronic care, and we can use this platform to document the time we're spending with the patient. So it allows us to qualify for that kind of reimbursement, which is really critical if you're going to build a program, that you think about what are all the avenues for reimbursement. The other thing is this entire platform qualifies for educational reimbursement, and about 40% of all patients that come into your clinic really could qualify for some form of educational reimbursement. And when you start building this program, and you can start in diabetes, you can bill for these MAP sessions, and when you have multiple people attending and one facilitator, the math works. You begin to have a profit center for this type of work that begins with the belief in the provider interaction, the physician or nurse practitioner interaction, and then expands into these sessions. I talked to a doctor in Philadelphia whose team has used these tools for high-risk patients, and not only did the sessions occur while the patients were traversing their diabetes or heart failure, they actually formed groups that met every month after the sessions and continued meeting with their health coach to talk about their challenges. And it's just a great way to keep people engaged. So what proof do we have? And we've got just a few minutes left, and I invite you to ask some questions. You can type those in. We'll be addressing those in a few minutes. But I think as I've looked around the world, this platform has more evidence than anything I've seen. And these studies are all independent studies, and they're driving hard outcomes like significant reduction in hemoglobin A1C, or a study from Taiwan that shows over 40% reduction in episodes of hypoglycemia when people start insulin, which hypoglycemia is a major driver of ED utilization. It's actually the major driver of ED utilization when people start insulin. It also is the driver of noncompliance. People who get hypoglycemia start not taking their medication. So when you think about building a platform that appeals to payers, you really have to have an evidence base that makes sense and a reliable tool that you're embedding in your system to produce results. A lot of the results in these studies also translate to HEDIS measures and star ratings and all sorts of measures that really help drive incentive payments with payers. So in my experience, the payers are very willing to hand over disease management. Employers would love if providers would do it well. But what people need is a platform. And I think of all of them I've seen out there, Healthy Interactions has got the components that really make something scalable, achievable, and doable. So I'd like to close this part by getting your thoughts in a poll here. And we're going to re-ask what now, having heard some of what we've said, where do you think your greatest opportunity is to improve your program or create a chronic behavior change program, chronic disease behavior change program in your system? So if you go ahead and vote, we'll see what you think. All right, are we getting enough votes to put up some results, and then Barbara and I will comment. All right, so it sounds like improving engagement, personal touch, and reimbursement still an issue. So here's what I'd suggest is that there are lots of ways to figure out how to do reimbursement, and actually the Healthy Interactions team can look at the data from your system and tell you what that opportunity is and actually help you solve for that. So that often takes a dive into your system. What are the unique parts of your system that need to be changed or enhanced in order to get reimbursement? So I love the quote from Socrates about this point in time that we're at in our journey. The secret to change is focus all your energy not on fighting the old but on building the new. And I've done a lot of fighting the old in my career, and I've been fortunate to orient toward building the new. And I think there's huge opportunity in this disease management space to build the new. And I think a lot of what we need to know is already out there. We've got a couple resources available for you. These are free resources. You can go out and look at the Healthy Interactions website, the studies that we talked about, the tools that we've talked about, you can look at for yourself. And certainly if you want an assessment of your system done, that's how you reach the team that can do the simple data analysis and tell you what kind of opportunity you have to improve the short-term reimbursement and begin creating the kind of tools you need to achieve value in your system. So let's move on and see if we have any questions.
Hi, Dr. Moen and Barbara. We do have some questions in from our audience. The first one is from Susan, and she's asking, how do I reimburse for DSME?
How about if I take that one? With diabetes self-management education and support, it's a fairly well-structured reimbursement. You have to be either ADA recognized, American Diabetes Association recognized, or AADE recognized to bill for the 10 hours within the first year. And then 9 of those 10 hours have to be group education, and 1 is one-on-one. And then for the following year, there's 2 hours. However, more hours can be provided if there's a clinical need for it. Like if your patient is not achieving their A1C goals despite of going to the classes, you can ask for more hours. So reimbursement is fairly straightforward with diabetes education.
The other thing I'm seeing is that we're beginning to see reimbursement for obesity. There's coming reimbursement for education for other chronic conditions as payers are seeing programs that work. And the key is to get a program started, get it working, and then begin working with your payer partners to make the reimbursement happen.
Exactly, and there's also group medical visits that could be done for blood pressure or for cholesterol. So those do not require ADA or AAD recognition, and it could be done by the physician and the partner with a diabetes educator or a nurse.
Awesome.
Okay, the next question is from Paulina, and she's asking, how do we get people to attend groups, and what does outreach look like?
That's a great question. So I've seen in systems that have adopted this, there's posters in exam rooms, there's education sessions for the physicians and the staff in the clinic. The most important thing of all is for the healthcare providers in the system to really understand the program and then invite their patients in. And we see in systems where the providers really get on board, a high number of their patients sign up. In fact, we've seen systems where they've not had enough classes for the number of attendees. They're reaching many more people than they reach with traditional diabetes education. So the tools that Healthy Interactions uses solve for that question really, really well, and they have the expertise and the experience, having done this for 10 years, to build your program from the bottom up, including how do you market this to your patients and providers.
Okay, and the next question is from Marie. She's asking, I was under the impression that billing for chronic disease management could only be done by the PCP. Is this correct?
Any licensed healthcare professional can bill for the Medicare code, the CCM Medicare code. It requires 20 minutes per month of time. Not all of that has to be with the patient. It has to be on behalf of the patient, and it needs to be appropriately documented. This is a code that's very underutilized and just beginning to get embraced by systems. And the big challenge systems have is the documentation of it and the training required. And to do it and not be at risk from a compliance perspective, you got to have an electronic infrastructure and a method that makes sense. And I think, again, Healthy Interactions has the tools that can make that happen for you.
Okay, and the next question is from Jackie. She's asking, how do you engage and establish trust with mixed groups, such as people who are newly diagnosed with diabetes, who are struggling with A1C, etc.?
Barbara, that's you.
Oh, that's me. Anything with diabetes is always me. How do I engage? Like from a perspective, I think that starts with the physician. It starts with making sure that our partners, that our physicians become that we, diabetes educators and nurses, dietitians, pharmacists, we have a good understanding and communication with the referring providers, physicians, because if that patient really, I would say the word belongs to that doctor, because they chose that doctor, they have the relationship with the doctor for years, and I think that if they are able to see that we are part of the team, with communicating with the physician, supporting the same goals, and then we're talking the same language, that patient is going to see us as it's going to be more engaged.
Great. The next.
And I think I've heard you talk about, Barbara, this notion of different people with different stages of the disease in the group and how that works. Tell us about that.
Yeah, it's very interesting because, you know, with the stages of change, a lot of times patients would be like, I really don't need help. I don't really have diabetes, and I'm only here because my doctor told me to be here. But what I see, like with with the group session, it's really actually interesting because the more diversified the patients are in terms of their perspective of their diabetes care management, once they get to the group, they kind of normalize things and they transition from the denial. And then the group is actually, the peers are helping them to transition to it. And that's why, like with the group sessions, what we're seeing is the very high completion rates, but the patients are coming back because it's dose dependent. It only works when patients are attending and utilizing the services. So like in many cases, there's like healthcare systems that it used to be a patient completion rate for the 10 hours was like 40% and went up to 80% because of that group interaction. But it takes more than just the healthcare professionals to get the patient to be engaged.
All right, I think we're almost to the top of the hour, so I'd like to take this time to thank you all for attending. We had over 100 attendees listening in today, and we appreciate your attention and the questions that you put forward, and certainly there's a lot more to learn. Here's how you access Healthy Interactions through the telephone. It's a great team. Barbara, I want to thank you. You're truly world-class when it comes to education, and I appreciated so much all your insights today, and thank you all for being with us.